dense in terms of subject matter. I've already heard this now fourth time, but you're barely hearing it a second time in some areas. So understanding it and won't be mastered today, but if all of you could just hear the key points and then piece it together as we continue operations. For the office staff, some of these areas is specifically for the physical therapist. But if you do not know and understand and have an idea of what your PTs go through during the day and what's required of them, then you're only coming to work to take care of the front and not making the connection to the clinic. And I always like to look at a clinic as once that patient passes the lobby into, that's a golden door. Because you all have cleared the patient for us and we get to see them, and the entire team always needs to know what's going on from a revolving standpoint, both at the front desk as well as the back part of the clinic. So when it's a little bit over your head, don't worry, just listen and then it'll all start gelling together. Let's first start with the CQ modifier update. We spoke about that last week. It is a requirement for traditional Medicare, no exceptions. Optimus gave me a response. His response, the gentleman was Hart Johnson. As of last week, he said, we do not have an exact date, although development is currently nearing a testing phase, so hopefully soon. Keep an eye on the Optimus PT homepage for announcements. I'm going to give you a little glimpse of where I think they're going to go because it's no different from G-Code. So let's go into our Optimus page. When you as a PT have already, when a PTA has sent you a document for you to co-sign, you're the supervising PT, so look at it from that perspective. The middle is this stuff. Okay. It'll look like this. So like in this case, I think it was Stephanie's and mine. So there's a little arrow right here. It's a green arrow. When you press that arrow down, this is what happens. You get a whole slew of modifiers. That's very, very billing driven. Sylvia's department takes care of all of that usually for us, but this is going to be the first time where a PT is responsible for selecting. And we anticipate that the CQ code is going to be right here. You just tap it, it'll come out, and then just like the the G code used to be reported, it'll be done in the same manner. And then you put them in every single CPT code that your your PTA turned in, and you close it. So. Staff, this is new for your PTs. This is going to take us easy 45 seconds or more, but it's time. And when you multiply all that, and you have to go to a different screen, so we're just and PTs, you're just going to have to embrace it. This is the world, regardless of where you work. Now, I don't want to go into details because we kind of went over it last time. If you share a PT that day, you're going to have to make your judgment call. It's a 15-minute, you all know the 822-minute rule. So if your PTA sees the patient that day for 2 of the 4 codes, you have to make sure ethically you choose the correct CPT codes that they saw, and then you saw, and however, you're the one that closes. Again, the advice that was given at the national level is try not to co-treat. It's not going to always happen, especially if you get a phone call. That's the example that they gave. You get a phone call, you have to leave, your PTA's eyes are on the patient, so technically you weren't there, or legally. And again, but his recommendation is try to avoid co-treating. That's why it is so important that when you do an evaluation and you walk the patient to the front desk, and you tell the receptionist in front of your patient, again, because you have already told them in the room, your therapists are going to be Chole and Stephanie, or circle the names there. That's why your pictures are there. It really helps us to start processing so that your receptionists know where to schedule that patient and avoid that, who does this patient belong to? Because once it's in the PTA schedule, then we're going to end up co-signing it, and we have to go through this process. Okay, that's it for CQ modifier. Most likely I will not talk about this anymore. When it happens, it happens. We'll send out a message and just start playing with it. Okay,
So-
yes,
But
yes.
it's effective January.
January 1,
1st.
it's January 2nd, because we start patient care. Good question. It's effective January 1. So we'll be doing it, and then Sylvia will be our catch, am I correct? You are very catch, so she'll just straggle the thing, has to send it back to you, and then we have to choose it. So just be a little bit, until we all just catch on. It'll take us a couple of weeks, give us something. All right, the 2020 G code and functional limitation, the FL reporting. Unfortunately, in Texas, we still have to use the word G code because the Texas workers' comp system still requires that we report G coding and FL reporting. So let's go over that. FL reporting is required in your documentation, and then the G code reporting is in your billing. It'll automatically come out like it used to for so many years that we did it because case management department, which is Lydia's division, she puts it in the system when the whole patient chart or file is getting started. So you'll automatically see that when you do your billing at the very end. You'll see that G code just pop up because you will have put it. Remember, it will always pop out in additional findings section, so you'll have to select the percentage of your FL and then the G code along with it. Okay, that's workers' comp, no change there. For Medicare traditional, does not require anything. So effective January 1, Sylvia is allowing us to drop it. So a little bit of help, you don't have to do it anymore. Let's go to Medicare MAPS. We, EPPTS, we've chosen to drop everything that is related to FL reporting in 2020 for all MAPS. However, there's a little but. WellCare, for some reason, they don't want to do this. They want to keep having us report. Or another MAP indicate payment is denied due to lack of FL percentage reporting. The business office will throw it back to us so that we can redo it. We voted, the leadership voted that it was best just to drop everything. We'd much rather once in a while do a WellMed, and we'll go, and I'll walk you through what we're supposed to do, than to have to report to everything this year. And one of the things I told Sylvia is drop something because we're picking up CQ anyway. So, try to balance our work. So she was willing to do that. So let's walk through what happens. When the business office submits a request to have the PT redo the note and include the FL percentage, you base it on either photo, but not all patients get photo. For example, TMJs, Bell's palsy do not get photo. Or you can use clinical tests and measures or both. But remember, and I asterisk this, FL percentage can only be based on that which was performed on the day of the evaluation. So whatever you have there, just grab a percentage, you already know how to do the functional limitation percentage, add it to your additional evaluations findings section like we always have, and then upon completion of request, insert the following in the edits section. This is why I want you all to save this handout. On the right side, just like we've always done, if we're going to put do not use document, this is what you'll use, is per insurance carrier request, this document reflects functional limitation percentage. That's it, right? Any questions on that part? You kind of work it through. I'm a phone call away, but I'm pretty good at returning my phone calls after 12. So just don't hesitate to call me. And then we'll both troubleshoot from wherever we are, and I'll guide you through the process.
I do have a question.
Yes, yes.
Let's take the photos for progress reports. Would that suffice, or it has to be strictly evaluation or evaluation?
Strictly evaluation, reevaluation. Good question. That sometimes photos are taken and for progress notes, or because will that suffice? If it was done on a day that was not a reevaluation or an evaluation, no, it cannot be used. That data cannot be used. So only that which is already documented. Because remember, you already legally produced document 1. You can't change it other than to grab the information. Good question, like that. All right, so it's this page. Oh, this is what I wanted to do. Just wanted to show you which page. You would go over here to the notes section, It's under document, when you press document, and you just add your note. And this is where it would be. Per insurance carrier, this document includes FL percentage. All right, let's go to something different completely. Medicare, traditional, and MAP. Now we're talking about reevaluation. So I need you all to stand up for about 30 seconds because this is a whole different baby. Some air in there. All right, let's go ahead and have a seat. I think it's important that we first start with the red part. I quoted the actual ruling from what we call the Aspen Federal Regulation Set. This particular set is when a Medicare auditor comes to audit your facility, they have a computer, the whole regulation set is in their computer, and they go one by one. Does this facility have this or do they not? And they start to score us, and at the very end, they just press the button and we have a score whether we failed or we didn't, or where we have contingencies. So let's start by indicating that it is from the Aspen Federal Regulation when we're talking about this. Now, Aspen Federal Regulation says that if you are an ORF Medicare certified facility, and we're an ORF stands for Outpatient Rehab Facility, the plan must be reviewed by a physician, nurse practitioner, clinical nurse specialist, or physician assistant at least every 30 days. That's why when you do your reevaluations, you have to do them every 30 days. Whether there is a clinical change or not, they want a 30-day evaluation. Different from if you worked for a private practice who is private practice physical therapy certified, they do not have to do one every 30 days. They can do one every time there's a significant change in the patient's condition. So real important for you to understand the why behind the 30 days. That's why for all Medicare, traditional as well as MAPS, you must do a 30-day reevaluation. The certified plan of care can go as high as 90 days, but your actual period of episode for that evaluation or reevaluation is 30 days. All right, so this is where that 30-day thing is, and that's why office staff, that's why you have to, by company policy, fax out that eval and reeval to the doctor and write down certified, because that's how when they came last year, they came, we were able to just consistently tell them where we put it. And we can't thank you enough for what you've done for us. You made the audit really, really nice, run smooth in that department. So every 30 days, fax it out. Whether the doctor got it or not is a different story, because we have to just make 2 attempts, but make sure you write down. Now, second part about this subject matter, let's now talk about billing, what happens in the billing area. When you're an ORF certified facility, you're required to submit more G-codes. Sylvia's life in her department is all about G-codes. They talk in that's their vernacular, that's their language. So they submit G-codes, and in the past, the billing triggered identification of an eval or reevaluation codes based when she would see the G-codes. So she automatically knew something was going on. It was either a 10-day report, it was an eval or a reevaluation. However, because we don't have G-codes anymore, she's having to go through a different angle to determine, did this patient get the 30-day evaluation? Now she submits, in her form, she's required to put in value codes of 11, 29, and 35, of which 11 and 35 indicates to the payer that's going to pay us that it is an initial evaluation. And that's pretty easy because it's the first one for Sylvia. But where she's having trouble right now is that the 29, which notifies that it's a reevaluation, she can't pick it up because sometimes you physical therapists are not submitting a reevaluation. Now we did a couple of audits, and it's mostly the new ones, so don't worry. The old ones kind of got the hook, but we all go through this when we're new. You're doing a reevaluation because the 971 164 does not come at the very end, you just forget to put it. It just doesn't even come in. You're bringing forward the treatment for the previous day and you forget to add the reevaluation code. So by not doing it, it's not coming out in the billing, and Sylvia has no idea that it's the 30th. There's another issue that we saw on a case where it's the Blue Cross Blue Shield map. The rule is that Sylvia has taught us is if you do a reevaluation and you do a treatment, they're not going to pay for both. So which one do you submit? And here, what we have to do, and Sylvia, just correct me if I'm wrong, we need to submit the 97164.
On the prescription, no, in the treatment, you did the grades down.
Yes, but you have to have the code in it, right, for you to be able to,
And you put 0.
and you put 0?
Oh, yes.
Yes. Just so you identify it.
Yeah.
But don't take it, it has to be carried. Okay, just want to make sure. So at the very end, you put 0 on the reevaluation code. That triggers to Sylvia, a reevaluation was done. And then you put this CPT code units on the CPT code section. This is probably where we're getting trapped a little bit. But she needs a reevaluation code at the very end when you're finalizing your billing and you're making sure there's not a red/green combo. Any questions on that? I thought it would be nice that you all know what she goes through. Not that these numbers mean anything to us PTs, but they mean so much to her. And so what she does is the minute she sees that reevaluation code, the 97164, she puts in the 29 and it clears and it goes through billing. If not, they're asking you, right, am I correct? Where is the 30-day reevaluation? All right. And then the last thing, as an ORF Medicare certified facility, we are required to submit that code. It is a reevaluation code every 30 days. So I think that was the most important thing in that area. All right. So here's another standing moment. Standing because we're going to switch speakers just a little while. So stand up for a little while.
I was, but I'm going to be else.
Whenever you're ready.
I think it's 30 seconds now. Can you guys hear me back there? Because I'm not myself today. I'm my brother. That's what my brother has, a real deep voice. So deeper than me. Okay, so outcomes report through photo. This is really important in that it's going to tie into the value-based stream that we are talking about for 2020. The medical professions reimbursement direction remains on course with value-based reimbursement resulting from outpatient scores for the healthcare provider. What does that mean? It means that for private practice physical therapy, which is PPPT, Medicare certified facilities, they have moved from reporting PQRS. If you aren't familiar with that term, don't worry about it. But they moved from that to using MIPS. We are not required to report MIPS because we are an ORF, like Chole mentioned earlier. For outpatient rehab facilities and CORF, Medicare certified facilities, we have to be able to prove an outcomes tool is in place. So EPPTS has always used, and thank God we do, is photo outcomes. With photo outcomes, we're able to prove to Medicare that we are using an outcomes tool to report our findings. EPPTS outcome tools photo is of course focused on therapeutic outcomes. Currently, EPPTS has always used photo to measure outcomes per clinic. Who of you here has not seen a photo report on outcomes? Everybody seen one for the clinic? Good. Wow. I'm surprised. So in 2020, starting January, we're going to initiate measuring outcomes per clinician. So I'm going to team up with Isaac in order to look at photo and put it into each individual PT's PC via Armando's help so that you all have a report ready as to how your outcomes are for diagnosis. Is it taking you longer to see a patient than generally, and if so, then maybe that's a weak part of our clinical manual skills, and so maybe we'll concentrate on maybe getting you better at those outcomes. So that's coming, and that's going to be tied into the value stream. The plan is that each therapist will have access to photo through their desktop, like I mentioned. But right now, we're just mentioning this. There's a lot of work that needs to be done behind, and so Isaac and I are going to be doing a lot of work for this, so we can get it prepared, and then we'll be training in the first quarter of 2020. So we'll be coming to you all and letting you know what it's going to contain, how it's going to be working, and how you can read your reports. So that's upcoming, and I think that, to me, it's exciting because we're going to be able to then direct the company to where we need to direct it more. I think that we've done a great job up to 2019, but 2020 and going forward, we're going to get even better. And so I need you guys' help. Thank you.
Oh, get a break, 5 minutes. All right. Let me answer this because this was, I'm this was his grant. When we were first moving towards it, he wasn't talking about it. He was just talking about all kinds of things. We're going to go so for example, she says, for example, this is because she said, this is
staff, right? Instead of staff. That's how it's can't explain those numbers, like if there's not somebody saying, like, hey, this number's different because you're seeing three different body parts.
So, at the National Health Society, they want to be the center. But I have and I don't know what was said by Marco, but there is but I don't want that to be town, because outcome is so summary of I told
This is hell. And it hurts for me. Especially something that's
They're going to low all the time.
outcomes.
Cool.
And he says, how many people in Texas? And I'm not by all things we were just okay, I'll type it. I can type it. Okay, let's go ahead and get started. All right. Let's continue. All right, y'all. Something special happened in Texas this year. So, truly, although it happened September 1st, I think the new revision was November, am I correct? Regarding. So, be aware that in the state of Texas, we now have direct access. It's in the version for Texas. Every state has it a little bit different. But I think it's real important because we are going to really direct or prepare a solid EPPTS future in Texas through direct access. And this is one of our marketing strategies and our strategies to make sure that we continue to be a very strong, viable company that offers services to physical therapy services to our community. So you can look at the middle thing. It's all centered around direct access. All of this information is coming from national level when Sylvia and I were at the conference. So we pulled it together and we said, how can we bring this back to El Paso and integrate it into what we already have and or improve our existing systems in these 5 categories. So let me talk about outcomes because we just finished talking about photo. One of the things that one of the speakers said is he says for those, he asked us how many were from Texas because he wanted to get a feel. He says one of the things that you all really need to, because the states that have been doing direct access for quite some time now, they said know how your outcomes are with your patients. He says because ultimately all these patients that come to your clinic through direct access, those are patients that are saying, I am willing to pay cash, or I'm willing to have you process it through my insurance to see if they'll pay, but I want your services. Because my neighbor told me that you have very good outcomes for shoulder rehab. And I think I have a rotator cuff problem. And so that's where we're going to use photo as a way to start getting our toes wet as therapists and getting our feet wet and starting to say, how do we do it? Because right now, and I'm speaking more to the young therapists that just joined us, photo tells you when you see a patient and you finally put in all the medical complexities and their age and their BMI and all their other conditions, they'll tabulate and say, like, for this type of patient, you should see this patient in 14 visits. Well, if you have a prescription that's for 18 visits, and you're saying, I can get this done in 12, there's nothing wrong with doing that. And I know that I'm barking up the wrong tree, especially, but you're going to have to feel good about what you can do. Because if it's 12 that you know how to do a shoulder and get it done the right way, that's what you're going to do. And you're going to have to work with it over time. Photo is going to be our tool. Everyone in America uses different outcomes tools. Some for all necks, and we did it for a while, use the Neck Disability Index, and then they get a percentage of all the necks, this is how you did. But we're going to play with photo. We're going to see how it works. You know, don't be afraid that if it says 14 or if it says 8 and the doctor's prescription is 12 and you feel it should be 12, use the 12, even though photo says 8. And work with it. Because what photo sometimes does not take everything into consideration. Number 2, photo will not take a 3 body part evaluation into consideration. So if that one body part, because we always ask a question on the most painful body part, it says this one should be done in 8, but you're also treating the other 2 parts and you want 16 just like the doctor asks. You see where things start to balance? And you know, stand your ground on an issue. Don't be afraid. But also, don't be afraid to do 16 because you do it. And I just had that happen a month ago. 3 body part. And so, but I said, which is the part that hurts you the greatest? And he chose the neck, so we did a neck photo. But certainly didn't take his 2 knees into consideration at all in the questionnaire. So we're going to work through that, but it's all into the future. It's the direct access. It's my picture is up there for the West Side community. And I'm Amanda, or I'm Rudy, and I am good at doing this. And so if you come in, because I've had 5 years of watching my photo, and I know how to rehab a shoulder, I know how to rehab a back. And I'm also not afraid to tell a patient, and I share this with my team at the East Side, but create a gap. We have this one patient, Mr. Hernandez, he's been with us for almost 2 years. He can bring me 100 prescriptions from Dr. Cromer. I can't see them. I can't. And he always brings them to me. And so what we do is we create gaps. And we actually discharge we do a DC photo. Let that photo come to an end. And then he's so sweet in Spanish. He says, don't worry, Juanita will tell me when I'm coming next. And then I said, but you have to wait 6 weeks, okay? And then he said, no, Juanita will tell me. So, but man, you think I'm like a mama bear with Jay, and said, you better do a photo DC. Because I know that if I don't, he comes back and that photo says he's been here for 6 months. So, you know, work it through, you'll work it. There's going to be a lot of mistakes you're going to go through. But our goal is about 2 years from now, photo feels real good. You're starting to say, I know how to do an ankle, and I know how to do a shoulder and a neck, and this is about how long it takes me, and it all eventually just balances out. So good outcomes is important to direct access. Many of the states are way ahead of us, so it's a joy to see like our company in a glass bowl and seeing our future. And I said, okay, it's very doable. You know, we're not afraid to face outcomes. All right. Efficient progress reports is real important. I'll go through that on the slide. Progress reports are your way of communicating with doctors. You're not in a hospital making rounds with them, so you don't get to see them. You don't get to make a comment about that total knee that's in room number 372. So this is where you really can communicate. And we've said this before, the more they see your name, the more they start to, and the format, the more they know who you are. So the efficiency on progress reports, because then the patient goes and tells their friends and their family how they're doing. Okay, the other component that we feel is really important is strong physician relationships. We'll be talking a little bit about our 2020 strategy there. I'm going to jump over here before I go to consultation. We are also going to be working on our graduation DC percentage, and you're getting your first report card today. So you're going to see how many patients you saw in October, and you're going to see how many of those actually graduated, that you got to say goodbye to them, that they didn't call back and say, oh, my doctor said that I don't have to come back anymore. Very different that when they're talking to their friend, oh yeah, I like physical therapy, Chole was nice, and I went to see my doctor and he told me not to go back. Versus, Chole was very nice. On the last day, they gave me a DC card and she wrapped up everything for me and I really enjoyed her. I beat the doctor. And that's what you want to do. If you're gonna be a community physical therapist, that's where you want to move yourself in that direction. All right, and then we're going to talk about a new program that's available, which is our consultation service that is going to be even more available in 2020. Okay. Let's first start with direct access patients. I do want to tell you that this is going to be presented by Lydia, Chelsea, and Sylvia, and it's a 4-section presentation.
I'm just going to go over some of the amendments that were made. This was to the Rule 322.1, which is provision of services, as well as Section 453.301, the practice by the physical therapist. So a PT can now treat a patient for 10 consecutive business days without a referral if the PT has been licensed to practice for at least a year, if they are covered under professional liability insurance with a minimum of $100,000 per claim or $300,000 per aggregate per year, has a doctoral degree in physical therapy or has completed at least 30 CCUs in differential diagnosis. And we also must obtain a signed disclosure which was created by the board prior to initiating the treatment. So for EPPTS's recommendations and processes, Chelsea, Michael, and Isaac can treat a patient without a referral for 10 consecutive business days or up to 6 visits. And the 6 visits is the EPPTS guideline that we came up with. So the patient can have approximately 6 within that 10 business day period. And that's from the initial visit or whichever occurs first. Chole, Amanda, and Rudy will need to complete 30 hours in the differential diagnosis before they are able to treat without a referral. A new graduate joining EPPTS cannot treat a patient without a referral. I didn't include it on there, but also in part of the amendments is if a therapist has completed a fellowship or residency, they can actually treat a patient for up to 15 consecutive business days. So the PTs will need to prepare a discharge plan from the initial visit to determine the patient's discharge date to ensure that we don't go over those 10 business days. So we do know that all patients are going to have different scenarios. We did come up with 4 possible scenarios, and these are in the handout. I'm just going to go over them briefly real quick. One of the scenarios was if the findings indicated that the patient will be able to complete the treatment within the 10 business days, no prescription will be required and the patient will be scheduled for the recommended visits and discharge at the discharge date. Scenario 2, if the findings indicate that the patient is expected to continue physical therapy after 10 days, patient will be informed that they will need a prescription from their physician before continuing past the approved dates or time span. When the patient's had approximately 1 to 2 visits remaining, a progress note will be completed to the patient's physician. If at the initial visit, the PT's findings determined that they wanted to continue, but then now at that progress note, they're deciding that no, we're going to go ahead and discharge, then a progress note wouldn't need to be done to that physician. They would just need to be discharged. Scenario 3, if the findings indicated that the patient is expected to continue after the 10 consecutive business days, the patient will be informed that they will need a prescription from their physician. But if the patient does refuse to go back to their physician or have us contact their physician, they will be discharged at the end of either the 6 visits or the 10 consecutive business days. And then finally, if the therapist does think that the patient does need more imaging or does need to go back to the prescription to get a prescription after that visit or needs some other testing done, they'll be giving one of our blank prescriptions and then referred back to their physician. Okay? And these are just some scenarios that we came up with. Like we said, each patient is going to be a different scenario. One may be easy, one may be a little bit more difficult, but just to give you an idea. Okay, so all direct access patients will need to sign a physical therapy treatment without disclosure form. This will be in addition to our EBPTS consent form, and it is in English and Spanish. We will have it for the front office, but I'll go ahead and pass it around so you can see it. But basically what the patient is doing is they're acknowledging that they understand that our physical therapist, they're going to treat them without a referral, and it's going to, their treatment's going to be based off of the therapist's evaluation and their examination, They also need to understand that the therapist will not diagnose any illness or disease, and that physical therapy is not a substitute for any medical diagnosis. If they already have a diagnosis from their physician, the therapist will take that into consideration. The plan of care will not be based off of any x-rays or any tests unless the patient previously had them done. The therapist can take those into consideration then. That they will be referred back to the physician if they do need any type of x-rays, and that they need to understand that their health insurance may not cover these benefits. So those are the consultants if you understand. In Optimus PT, instead of having a physician, it will have self-referral as the referring physician. So that'll be in Optimus PT. It'll come out on all the reports or anything that's sent to. They will appear in your schedule in a bluish color. And for the plan of care duration, we will need to reflect the maximum amount of days the patient can be treated without a referral. So when you're setting up your plan of care duration, if you can select your duration as being 2 weeks, if we're going to see them for the 10 consecutive days, and then if we had one that had the fellowship, or those would be the 15 days. So the example was October 2nd for 2 weeks, which will expire on 10/15. So that patient can be seen for up to 6 visits within that time frame. The document type will be an initial evaluation, and we just need to know that some patients may have coverage under their health insurance that will cover the therapy, and others will be on a cash basis. And so we'll go over that cash basis with you all. For Medicare patients, they will require still an MD signed plan of care from that initial visit.
So you're basing, I'm sorry, can we go back a little bit? So you're basing the 10 consecutive business days on 6 visits, like 3 times a week. They couldn't be seen 5 times a week?
They can if you, yes.
Yeah, if you determine
If
that,
you
right?
determine it,
Yeah, only
yes.
times a week.
Yeah. Yeah, so the 6 was just like an average that we had selected, assuming that the patient wouldn't come 5 times a week. But if you do have a patient that you do think needs to come those 5 days, oh yeah. We just need to make sure that we have it documented in the
Thank you.
question.
Okay, so I'm going to talk about how the direct access patient was a little bit different than the usual patients that we see that come with a referral. So I wanted to do it in the SOAP note format, for those of you who are familiar with the SOAP note. So the subjective. When I was doing the direct access eval, the questions, I asked the same types of questions that I did with a regular eval, except they were just worded a little bit differently. So I would say, I know you haven't been to your doctor, but have you ever had imaging for your low back? Have you ever had injections for your low back? Whereas before I would ask, okay, you went to Dr. Hernandez. What imaging did he take? What prescriptions did he give you? Did he give you injections? So I asked the same questions, they're just worded a little bit differently. Let me see. And then at that point, or towards the recommendations, you also want to ask, who is your primary physician, or who would you like to go back to if I feel like you need more therapy after the 5-6 visits that we're going to see you for. For objective, remains the same. You take the same measurements that you would do any other eval. The assessment is also the same. You create your problem list and then treat off of that. The plan, like Lydia had mentioned, you want to write, like how we usually do, recommending physical therapy at a frequency of, and then whatever you determine, which will expire in 2 or 3 weeks depending on what type of PT is doing the eval, and then the date that it's going to expire on. At that point, you can also determine whether or not you think that they're going to need more PT at that point. And then if you do, you want to write a progress note using a template that we're going to create, asking for more visits. And then I had a question that I had asked Chole, and I actually emailed the board. Let's say that you DC them after the 6th visit. They can't come back the following, like Monday or Tuesday, for the same condition. They have to have a referral at that point. Okay, but as far as the differences, it was pretty much the same. You just don't have a referral to write the frequency. You have to do it on Optimus. Does anyone have any questions for me as to how it went, or?
Is there a duration, say discharge, and is there a duration they have to wait before they come back?
I asked that question and they said no. And when they're discharged, they have to come back. If it's for the same condition or body part, they have to come back with a referral. I was wondering that too, like what if it's 5 years or 6 years, but they didn't answer. They just said come back with a referral.
For the same body part.
For the same body part or condition.
And again, well, we are gonna meet with the front office staff before the compliance meeting is done, so we're gonna go in more detail. So they're gonna be for the professionals, the people to go to for any more questions, because we're gonna go in detail with processes and procedures with them. On the billing, again, we can use, the patients can use the insurance, and the front office will get their information. However, we need to verify benefits and make sure that that insurance covers for direct access. And there is also, Lydia, the language, because a lot of insurances, they don't understand what do we mean by direct access. So it's actually more the prescription, if we have a prescription, if they cover benefits for without a prescription. But again, we will talk to the front office on that area. On the billing, so if it is the insurance, once we verify benefits and yes, the insurance will accept, then we bill normal. So you will bill your regular CPT codes, the evaluation code and the treatment. So the 97110, the 97140, all the codes. However, when they come on a cash basis, we wanted to be able to run a report and see how many patients are coming through direct access. So we're going to be using the unlisted CPT codes that are available for us. So for the initial evaluation, the fee will be $125, like the 97161, 2, and 3. But the CPT code will be 99199 that we will need to be adding in Optimus. For the therapeutic procedures that you use, then you're going to be using the unlisted one, which is the 97139, and it's a flat $50, like your regular therapeutic exercises, manual therapy, or therapeutic activities. And of course, the units is going to be determined by the physical therapist, so you will do the same as a regular visit. It's not, just keep in mind that it's not a private pay, because for private pay we have a different your $125, your $75 for private pay. So No, this is a regular, you are gonna bill for your services. This is direct access. They decided to come in to consult, well, not to consult, to have treatment because you are providing a treatment. So it's a full charge. We also added the 97014 because you all use it a lot and at the beginning of the stage of the treatment. So you will have the $25 there. And again, it's all determined by the PT regarding the number of units that you're going to be billing. So that's it. Do I need to go in? Which one is it?
So will they have to pay that up front each visit, or is it
Yes.
a bill?
No, it's collect the money upfront. Good friends forever.
Same thing for the treatment and before it's provided?
Yes.
All right. We had a successful first direct access. So thank you to Lydia's daughter who came in and Chelsea for doing it. And how much did we get paid already? Do you know? But they approved it, right?
Yeah, they approved it. They
Can
passed
you
it.
imagine? And so we have, just like Chelsea said, just another venue to bring in patients. And this is where your outcomes now start. You start to know so much about how you can do things that it's just a beauty. And we're grateful, we're very grateful, like Rudy said, to be able to offer you the photo outcomes tool to just learn off of and see yourself every, and you're just gonna tap on your desktop and you can see it whenever you want. It's always gonna be alive. And photo in Kentucky is the one that enters all the data, so you always see a report card about yourself. All right, let's go to consultation. This is a new service that we have available now for our company. It will be on the webpage, Margot, or is it on? I'm sorry. The
Yeah, the
consult-
last message I sent, I was waiting for final approval to put it on.
Okay, all right, so, and we still have till January 1st. So, consultation, our message to the public is gonna be that a physical therapy consultation is an appointment between a physical therapist and yourself to discuss your concerns and symptoms and provide the best course of action that will meet your needs. We wanna be available to the public, and our consultation fee is gonna be $35. There's gonna be times when patients just wanna ask you a question. That happened to me yesterday. That's not a consultation fee, but if you want to bring that person in, why don't you come in here? We'll discuss your case a little bit further. There's a $35 fee. When it comes to the registration process, you're going to refer, office staff, you're going to refer to the case management or what we call the patient intake procedure book. So Sylvia and Lydia will go over that. Your schedule color is a really pretty cantaloupe orange. So it looks nice on the schedule. So that's the color that you will code. It'll come out and you just select it. The time frame, you're going to put a slot for 20 minutes for that therapist. Okay, that's all the therapist gets. Get in, and we don't do anything other than to have them come into the room. Your documentation, you're going to only have to fill out 2 sections in Optimus, and that's going to be the reason for the referral, very subjective, and then go down to your recommendation section. Proceed to the document visit tab, then go to the new patient document tab, and choose report tab, because automatically it's going to say initial evaluation. So you have to switch it to consultation. And then create your document and sign it. And so if you ever want to see here, when you have 2 sections filled out, that's it. You consulted with them, they stay in the Optimus file forever. All right, it's real important for you to know that a consultation is not a treatment session. You cannot treat that patient that day, nor can you give them an exercise to do. You can talk about stretching, but you've got to be real careful. I did this for many years with El Paso Natural Gas. It's a real fine line. Yes?
The difference between this and evaluation.
An evaluation, you can evaluate.
So, I guess I'm just not understanding what this is being used for.
Consultation is that when patients, let me give you a scenario yesterday, because that happens. This lady knows me via my daughter. She says, I understand. She says, I just want to, I understand that you do urinary incontinence. I said, not anymore. She gave me her story. And then I said, my advice to you is that you go in to see Kathy Roth for referral. Had I been doing urinary incontinence. Why don't you come in for a consultation? Let me see what it's all about, and then I'll give you my recommendations, whether I think you should go get a prescription to be seen by a
But
doctor.
you're assessing her and testing her.
I'm not testing at all, it's just a conversation.
So you're basing your recommendation not off an assessment?
Yeah, because you're only doing a consultation, that's all you're doing, you're having a conversation.
How accurate can you give a recommendation without an assessment?
You can give a recommendation by saying, I recommend that you go see a doctor.
So I can
I think you
evaluate.
do have a condition that merits being seen by a medical physician.
Without assessing?
Now, or I recommend that you, yes, because how many friends and family have put you in that situation?
Yeah, but I usually put my hands on them and do a little bit of testing just to kind of see
The
where
other
this
day I
is
didn't
at,
put
I'm
my
not just,
Yeah, the other day I didn't put my hands on my.
well, no, it's urinary incontinence.
Well, no, this was, no. Howard's nephew asked me a question. I didn't put my hands on him, but I pretty much knew. I said, you know what, just based on what you're telling me, this is my recommendation. I think, and I did say it. I said, I really think that you have a meniscus, but I haven't tested you. I think you should see a doctor. And that's what I did. And so what we want to do, well, the thing is that,
Can we assess?
remember, we're moving towards direct access. How much confidence, ooh, I should be standing in front of you too, sorry. How much confidence are you all gonna have as to when do I consult? When do I evaluate without a prescription? Because in Texas, you can evaluate without a prescription. And when do I treat?
So who's setting this up as a consultation?
Who said,
If front office?
if they
Who's
want,
making that call?
yeah, if they go in and in our webpage, they say, I would like to have a consultation just to discuss my concerns and my symptoms.
I had a.
We want to be available to our public. I'm sorry, let me just see what Mike has and maybe we can connect something. And we'll get back to you, Amanda, I don't
So
want to
like
stop.
kind of muscle testing, like incontinence patients, like if she just says like I have, 5 episodes per day where I leak or whatever, then, that information, you don't have to actually examine them and do any testing.
For example, she told me 4 years ago she had a prolapsed bladder and, which she went in surgery. She says, I was doing well, I went to physical therapy, but now I'm just leaking all the time. That's a significant amount of information.
Yeah.
I don't want to do anything other than advise her.
I guess I'm being more like a shoulder. Somebody comes in, got shoulder problems, I'm gonna ask them to lift their arm over their head to see if it's a torn rotator cuff or something that I can treat before I'm gonna go in there. I'm gonna do a little bit of, look, I can't just,
Let's take that
You know.
same scenario, and the way I would do it is, what's been going on with your shoulder? Well, Charlie, I'm having a really hard time elevating it, and when I lay on it, God, you guys, we already know what that is. I haven't even touched it. I haven't even asked them to elevate your arm. I don't want to. They're already telling me. So that's the way I would do it at a consult level, at a consultation. But if I felt like I needed, why don't you come in and set an appointment so that I can do an evaluation? Because I can evaluate without a prescription. And we can determine at what time. And take it from there. Now, you have to deal with insurance. Because some insurances do not want to pay for an evaluation without a prescription. I said, so why don't you check on your insurance, but I'll be happy to do a complete evaluation. Now, I can't treat you without a prescription, but I can evaluate you. So you're walking through, but you made yourself available for the shoulder. Only because I love shoulders, so I knew exactly what to do. I knew exactly what to say to that patient. But when they tell you, I'm having a hard time taking a bath, I have to do this, and when I lay down, you and I both know what's going on.
so right there, why can't you just turn that into evaluation?
I can, but they
And
quoted
knowing-
me for 20 minutes.
Well, what if,
And they don't know.
If it's a torn rotator.
But they don't know yet that now you're opening up, and what a beautiful opportunity. You got a consult for 20 minutes, and it's gonna move you toward an evaluation. Let me see if I have an opening, I can see you right now.
What if you don't? So what if
And
they
if I
come
don't,
back?
pardon me?
What if they don't come back and
They
you miss
don't
that
come back.
opportunity?
They don't come back.
But you could have done an eval.
No, Amanda, because we're talking about consultation. You did not do an evaluation.
No, what
because-
if I turn it into an evaluation?
Oh,
And I
yes, that
keep the
moment.
patient
And
versus
if you
sending them
think that
away.
it's not gonna interrupt your schedule, absolutely. Did you all hear that? I think that's a great idea. Comes in as just a second, comes in as a consult, and you also gave a 20-minute, and right at that moment, that patient's willing to convert into an eval. That is excellent. Amanda goes out, says, I'm gonna turn this into an evaluation. You go out to our team, our front team, and the patient's there, and I already saw my schedule, I can squeeze it in for an evaluation right now.
Yeah, it's good.
Is that,
Do
am I
we
following you
reimburse them
correctly?
35?
Pardon?
Do we reimburse them 35?
Yes,
Okay.
absolutely. If you're converting to a 100, and they're gonna pay, and it's already been cleared. Now, hold on, because we don't like to just bring anybody in without making sure that they pay the $125. It hasn't been cleared by the insurance carrier. So it's gonna cost you $125, and then in the meantime, we'll go ahead and get it cleared. Am I correct, Lydia? Is that my answer? But yes, you monopolized on a moment. Is that the way you say it? Yeah. You took advantage of a wonderful moment and converted it into that patient. Okay, yes.
But, I was kind of along the lines of me, but to Amanda's point, so if she has this person in for a consultation and converts them into that evaluation, same day, right?
Yes.
Then would we say they'll apply that $35 towards the evaluation? So,
Yep.
okay,
Yeah,
that's good.
and I'll take over your eval schedule, you can do that one.
Yeah, we see nothing but opportunities with this consultation opportunity. Mike, did we address?
Yeah.
We did. We see just opportunities, and that's kind of the message we brought back, Sylvia and I, to our clinics is there's opportunities out there that we don't realize were there, and we're not afraid to try it. Now, like anything new, we're going to come up with some glitches, but we just have to experience them. Because if you never try, you're never going to move forward. We won't.
I do have a question, just to piggyback off Amanda. What criteria goes into consultation? Is it strictly the potential for physical therapy? Because I had a patient come in just for consultation on what walker she should get because she's malleolar fracture. And so I was in the room for 15, 20 minutes with her. And so would that fall into a consultation?
No, you're already telling a patient what to use.
Okay.
Yeah. So you went into treatment recommendations.
Okay.
Yeah. I don't have the vernacular right now, but when I was consulting with El Paso Natural Gas, I was able to go up and do an evaluation, but I could not treat. It was the hardest thing for me. I could not recommend. The only two things I could recommend, OSHA says you can do ice and you can do heat. That's all I could recommend. I couldn't recommend a stretching or go on. I wanted to, so no, you can't go into anything else beyond that consultation. But what's going to attract them is this statement on the webpage. It's just, we really studied the verbiage and we said, public has concerns and they are experiencing symptoms. And we want them to think PT when it comes to this. We are the experts. We know what to say. We can move it. So be very careful. Just no treatment of any kind, no recommendations. No recommendations on. But a recommendation at the very end is refer to a physician. It's going to be that simple, because we can't recommend anything else. Yes, Sylvia. And then I'll come back to you.
And I think for right now, the key is teaming up with your front office staff, since it's a new direct access and consultation. So that way, it's a team effort, and we educate our community, which are the patients, on how we can best provide either of the two services. So it's more a team communication effort, is the way I see it.
Okay.
And to go off of Sylvia's point, the consultation will give us the chance to explain direct access a little bit better so that if they don't want to go see their doctor, we can always give them the option to come in for a direct access.
Oh, evaluation. I see you guys are thinking. We didn't think of that one. Okay. Chelsea.
Can we use this for open gym consultation? Because I've had someone come in and say, I saw somewhere you have open gym, but I've never been a patient. But I want to know what they want to work on and their medical history, because we don't know if they have a heart condition or something. Can we use a consultation for open gym, or that's something different?
Yeah, that's something different. Yeah. Open gym is open gym. You really want to just keep them as an open gym patient.
But you
And
just
you
spend
can-
time setting up the program and talking to them about health.
But they already paid $25 per month. We advertise it that way. Now, if you have a consultation, and you still charge the $20 to $35, you recommend open gym. That's a whole different, but they should pay you the $35. They took your time. We hope that this is going to open some doors. 2020 is about creating opportunities to open new doors to our practice. Okay, let's talk a little bit about 2020. Juanita does not know this. Where are you? She's going to help me. You're going to help me on this presentation. Very little, not a lot. Surprise. Okay. We want to introduce a new term to you that we're going to be using in 2020, and that's called Key Operational Indicators, KOI. In the business world, you're very used to hearing the word KPIs, which are Key Productivity Indicators. We use those at our whiteboards. Every week when all of us meet at our prospective clinics, we go over all the regular KPIs that we have to be looking at. Every industry does it. Every industry. We're no different. So bottom line is you have to measure to see where you're going and how far you can get to your budgeted goals. So never be afraid of visits and numbers. Never be afraid to be hearing they're pushing visits. Don't look at it as a push. We're a business, and visits is what we sell. Walmart is constantly looking at shelf life. They measure that like nobody's business. How long is that thing staying on the shelf? And the pressure's on, and they report their KPIs to management every single morning. Walmart was amazing when I heard some of what they report at their morning daily meetings with their managers. So we just look at visits and not be afraid to say, this is what it takes to make a clinic viable. So we're going to be looking at number 1, graduation DC audits, and our goal is that we get ourselves to where we're graduating 70% of our patients that we evaluate. We get 70% of them to graduate with us, that we get to say goodbye to them. And the next one that we're going to be measuring in January 1st, to start fiddling with it and see how your clinics want to measure it, is you're going to measure the self-referral rate. So self-referral means any patient that came in because they did either been our patients before, or they said, I had a family or a friend that told me to come here. That is classified as a self-referral. When it comes to Optimus. Our referral will be entered into Optimus, and our goal is to get 45 to 65%. This is a broad spectrum. Sylvia's class had one percentage. I went to another class, but we just kind of want to get started somewhere. So Juanita, if you can just come up here for a little while and just talk about what screen you open in Optimus and enter. But over here. So office staff, this is what she's doing. We just wanted to experiment, her and I, so that we get an idea of what to say.
So basically, what Chola's saying is that when you're creating the new episode of Care, it's right there in that section, right above a body part. It's going to see if it's being a physician, referred by a patient, or self-referral. It's going to be right there. You just click on that section. And then at the same time, if you know the patient's going to have an appointment with the doctor, just go ahead and enter it there as well. So that'll be letting the therapist know when it's the next appointment with the doctors.
And then Sylvia is going to be helping us how to tabulate that information from Optimus. Thank you, Juanita. Now, you're going to be in a room with a patient, and Juanita knows that they got referred by Dr. So-and-so, but then you discover in the room that this patient got referred by a friend. You all need to go out there. You need to really keep that, start keeping your percentage. Because if you don't go out there and change it, which is what happened to us, I went out there and told her, by the way, Miss Christensen, and then we ended up sending her a referral card out because she referred that lady to Mrs. Snyder to our office. So these are the 2 new ones that we're going to be monitoring. All right. So let's go on to our graduation DC audit. Our goal for this is for your patients to speak to others of their last visit with you. That is your ultimate goal. And so we're excited about positioning our team in 2020 to have your community know who you are and have previous patients speak of your skills and your talents. And so let's now, for the first time, unveil your first one. It's not going to be up. You're all going to get it. Sylvia's going to pass them out. And just take a few minutes to look at your graduation. First, graduation audit. These are all the evaluations that you all did in October. And look at your percentage. It's at the bottom. And see where you are in relationship to 70. We want to thank Robert, who
Robert Main.
is a PT tech here who took on this project with me and graciously. Great. Okay, team, just be patient because your PTs are looking at their graduation audits.
But you know, if you kind of find your way it took me so let me show you.
Surprise, you guys.
She still has 41% active. She only got 9% of her patients got to speak. And these are vitamins and coffee just come out. Well, I can make that work. I can already see that.
All right. So when I did my first report card, mine was in September, it was embarrassing. I had a 21%. So I think it's real important that this graduation discharge report, lots of private practices across America have been doing this. I got to speak to a couple of directors that have been using it, and they said, but the funniest story was this. One director told a brand new therapist, who gave him her first, and she has a team of one of herself and one PTA, so together they co-treat. And she says, oh no, she says, I've been doing good, my patients are happy, and I'm really happy with the outcomes so far. And when he gave it to her, she was shocked. She says, what do you mean? And so what she discovered that there was, the communication between her and the front desk had to improve. She discovered that the PTA and her had to talk more. She said that he said to us, she discovered so much about even herself. You know, what approaches do I have to take to make sure that my patient gets to say goodbye to me on the last visit? So, you know, she's, I guess, using Chelsea's words, she says the challenge is on, and she just soared the next month. You know. So recommendation that he gave is to always go 2 months before. So if you notice, we went to October, because the average patient stays with you 6 to 8 weeks. That's what the average. So he says work always 2 months behind. So we gave you your October to see where those patients are as of right now, and then we're always going to be moving it forward. Armando, moving our company forward, will be in charge of this, and he'll always give you your graduation rate. We'll be looking at it as clinic directors. We're going to see how you're doing. But this will give you a chance to start saying, does this patient want to drop off on me already? Can I tell? What are we doing? PTAs, this is where you're going to have to pony up with your PTs. And we are a company that every single clinic has a PTA. So just learn how your PTs work. You know, keep shouldering with them. And if you're responsible for that patient for the whole, you know, care because your therapist has told you that, up to the time that it's time for a reevaluation or whichever parameters they put, just make sure that you're staying, because you want that patient to graduate with you. You do not. You want to be able to say goodbye to both of you by the time the patient goes. So this is yours to keep. You're welcome to show it to your team if you want, but this is for your eyes. And you're shooting for 70%. The gentleman from the East Coast said that they worked their way. It took his entire company about almost a whole year to get to the 70% in that range. So, good luck, and this is going to position you so much better for direct access. All right. Next thing is we're going to start doing, in 2020, we're going to do what we call a new physician relationship program. We've used this word before, and then we dropped it all of last year. I think we used alliance and engagement, patient engagement, physician engagement, but we're coming back to the word relationship, and I just kind of thought I'd do some interesting things so it doesn't get too boring. In the dictionary, it is a noun, so please remember that. And it is the way in which two or more, and I underline, in this case, people, are connected. So we have every intent to make a connection with certain physicians this year to get ourselves started with a relationship. The study will assess the relationship between unemployment and political attitudes. That's the example that they gave when I looked it up. So we're determined to meet up with physicians, and in 2020, this is our commitment to start the year off. We have Dr. Eric Torres, who's on the west side right now. Rudy will be partnering up with him. Dr. Gonzalez Sandoval, an east side orthopedic physician. Chelsea will oversee. Anytime Keith Johnson comes up, Rudy is also, and so at the other clinics, you all, if you're seeing someone from Dr. Johnson, you know, and you need something to know something behind the scenes, call Rudy. That's real important. Eric Sides is going to be Amanda's. Dr. Onadika is mine. James Bean is Chole, and then Dr. Edgar Fernandez is Isaac. And this will be a wonderful time to make a general announcement. Mike is leaving our company January 17th, so he's not up here. So we want to wish you a warm departure, because I don't think the whole team is going to see you. So thank you for the years that you gave us. He's moving back to Austin and with his family. And I will cry on the last day, because I will miss you. Anyway, and your man cave partner, it's in your man cave right now.
Stephanie.
Stephanie lives with him during the day. So this is what we're going to do, and we don't know what's going to happen, but we're going to try something, and we're treading uncharted waters, but we're going to make it. Okay, this is our commitment for relationships and to help Margot during that process. Oh, why did we choose ortho? One of our consultants asked us, do you have a relationship with ortho? And we didn't say, we couldn't say yes. We have relationships, I know I have 2 relationships with internal medicine. So ortho is very driven with physical therapy. They go hand in hand, all in the United States. So that is why, one of the reasons why Rudy and I decided, what can we do? We are sure that probably some of these physicians have relationships with other PTs, but we want to be one of those 2. So that's why we went ortho and PT. Thank you. All right. I think we need a break right now. It's just 30 seconds. This is another part. Bathroom. Oh, tell you. I'm like a right there. Give it
one thing I like is that I could there with patients. General conversations with them.
So it's enough laughing and having a good time.
But like if you tell me Tucson, I can rattle off a bunch of names. Go to this person for shoulder, go to this person for hip, go to this person for hip, go to this person for you know, because I know that they're out for and I
You know it all, because we're hanging out.
Oh my God.
Basically, that's us.
I want to get on this inside joke. It's okay. It's okay, like I should know. I told her. That might seem that.
You know what? My technique was out there. I was doing like this. I should know people fight. Like, how I realized that at the end.
I just optimized today.
And then I just kidding.
CrossFit.
But you know what,
I think I can get
it
out
would be a challenge that you can do
I cried big.
what specialty? So that we all can stay in.
I just want to come out. I want to get like,
Yeah, and
you know, when I mean, yeah, you know, you're seeing.
Oh yeah, you get the girls do like
Well, my high school work at PK was supposed to be like
I can tell the difference
circumcision, you know.
We're going to do it. We knew the timeline, okay, so we were pretty much good to go.
I mean, there's trees and stuff
Like
like
what I'm saying, like,
yeah, there's a bunch of trees, January, cedar, and art. It's not still part of like a major city. It's
Oh, we post next. Okay. And we can talk about it.
Not really, it's not, but it can. When I open wide like that, my teeth are great.
the other house we looked at was like $1,700-$1,800.
At least you don't have a. Oh, but you can at least bring your teeth over. You can at least bring your teeth over. I can't even do that. Like, it's hard, like, yeah, but it's not so. See, mine would be like, kind of like,
And I think that's why
pretty much an overbite, but it'd be normal. 8 or 10. Maybe overbite. At least 2 weeks. I'll do it like but I'm gonna lose a lot of weight. I'm gonna get on the diet for like 4 weeks.
All right, okay, let's go ahead. I was talking to Stephanie during the break, and I think it would be a great idea if next February, which is when our next East Side hosts the next professional meeting, if you all could come back and everyone stand up and say something new that you've learned about your prospective physician. One of the things I was telling her right now that I do know that Onedika is pediatric board certified, so besides being an orthopedic surgeon, but I'm going to do a little bit of research and all of us can stand up Because the more that we know, comment that she was making is, Doris, is he doing an anterior approach? And I think he is. Does he use a glue? Does he use staples? Does he use the zipper approach? And when does he take them off? And when does he come? When does Dr. Doris like them to go from a walker to nothing, or to a cane? So those are good things. I think if we can just start digging a little. I have a patient from a physician in San Antonio, and he wants 6 weeks of a walker. That's him. She's doing very well, but his prescription specifically said. So the more we know a few nuances about these physicians, I think is going to be great for us. So if y'all could be ready, that's a good challenge for us next February. What 1 or 2 things can you say about the doctor that you all are following up on? Okay.
I can tell you something about Johnson that you would like.
We'll ignore what he's I've always called him my day husband. And Albert really is now just my night husband. I used to see him during the day, but not anymore. Okay, let's go on to progress reports. For all of us to have good uniformity, and I've seen it, and I really want to commend the entire office team, because we are now, all of us using the same progress report, what we have called progress report. Take note of these little verbiage up here. It is now called reason for status visit. When we changed it and we piloted it last year, we used these. Alyssa, Chelsea, and I came up with that verbiage when we were making some major changes a year and a half ago. So, but the office staff still looks at it. Now, PTs, what I want y'all to know, the office staff has been trained that when there's only 2 more visits left over in the episode of care that's showing up 2, that prompts them the night before. If it says 2, they produce a green sheet, period. They do not know why it's coming to an end. They do not know if it was a map that required pre-auth, that you asked for 12, the doctor asked for 12, and they chose to give you 6. They don't know that. All they know is that the patient has finished 4, there's 2 more left over, and you have to do something about it. So this is why we want you to keep looking at how the design of the report. Dig into a little bit more. The left side has its reasons. It should only be filled out by the receptionist. Because there might be a period of time where this patient has not been here for 2 weeks. And you certainly want to be in that room before anything starts. So team leaders, if this is checked off, don't bring the patient in to do exercises. Please do not do that. This means that you stop. Take them into a room and have them speak to a PT first. Because you really want to know what's been going on for 2 weeks. The therapist may have known that they were going to go on vacation. Oh, don't worry, I know they were coming back. Let me just see them. And you say, well, Chole came in and out so fast. But there's other times when I found out that one of my patients had abdominal surgery and he couldn't pick up things, but the doctor had released him. So different things happen, okay? So take a look at this. Then you go over to the team lead. Team lead, you need to make sure that a second photo is done after the initial evaluation. Photo will not count the episode if you do not have a status follow-up. If you only have the initial intake and nothing else, it was a waste of your time. It will never get followed up, so make sure. So anytime the last 2 visits are coming, it prompts the team leads to do a photo up here. I like what you all do. I don't want to get involved. I think it's working. There's a few that get missed, but in general, it's working out here. Here, you don't have to use it. I just want to tell you what it's for. There are times when I need to, a PT may be busy, and a PTA may need to just take range of motion measurements or test measurements. Because what's real common, and Westside, you all need to get ready for this because we're seeing your numbers go up on MAP insurance carriers. Where you ask, the doctor wants 12, you want 12 in your plan of care. Insurance gives you 6. Just because it's a green piece of paper does not mean that you have to bother the doctor again. Don't bother her or him. They already gave you 12. You need to start learning what does Lydia need to get you the other 6 that you want. So, and Lydia's rule of thumb is fill out your daily note with full measurements and retesting, because that's what's going to allow me to get more. They may want to give you 2, they may want to give you, there's a lot of little tricks, I don't want to get into them, that you can do, but bottom line is that you need to know why this green sheet was produced. And truly, the PTA and the PT are the only ones that will know. Train your new PTAs to start thinking this way as soon as it's early. I mean, they have to get their feet wet the first 3 months, but start getting them into the world of MAPS. All right. Then we are going to, you have options. Start communicating with your front desk. And it was designed so you didn't have to get up from your desk or leave your patients and go tell them verbally or put a little sticky. We designed it for you to communicate via this sheet. So the patient wants to get discharged, decide what you're going to do, you want a progress report, do you want to keep this, do you want to keep it? I'm going to make all my decisions on the last visit. But regardless of what you do, you need to fill out the bottom section, which is your initials and the date. Because what Sylvia really wants to work on, and Westside is going to be our model that we're going to be following right now, is that once the green sheet is completed, it's been returned to, if it's routing to a DC, that's going to then move towards what we call the DC discharge process that our company has to do. Because in this company, first of all, let me say, in the Texas Practice Act, physical therapist, you are obligated to write a discharge note. If you do not do one, that you're going against the Practice Act. But you must notify, it also says you must notify the referral source. And so one of the ways we automatically refer is we send the photo discharge automatically to it. So this is all part of that process. We're saving you some time. Some of us do DC progress reports to the doctors, some of us, not all. And you don't have to, okay? I do it only on occasion. Some of us will write a little note, please send last discharge report to physicians. And other times you don't need to, because the doctor already knew you were going to discharge him anyway, so don't inundate him or her with more information. You already wrote it down. So you're the one that knows the case the most, and but write it right here, because from here the green sheet takes on goes into a new road for our practice in order for Optimus to eventually have the final closure of the case. So the takeaway for today is this has to be completed. And if you want to write a little extra notes, feel free to, but this has to. Office staff, I'm just going to ask you all to hang on to these a little bit longer. So I'm going to give you a time frame. You can just hang on to them for 2 months, because Sylvia and I want to do some audits. So it's a 60-day, keep them somewhere in your drawers for 60 days. Once 60 day expires, throw them away. You don't need to see them anymore, but we're going to be looking at some patterns here to get us through that process. Okay. Let's see. And then lastly, almost lastly, the value stream. We introduced it to you all a couple of weeks ago, and what we now have taken this to the next level that we envisioned. First of all, remember that on this side of the stream, they are customers still. They're not patients yet. We're trying to get them to cross the stream all of 2020 and then eventually touch base with each one of us internally. So external marketing will still be Margot, and one of her big missions for 2020 is to get real creative with the social media changes that you'll be seeing. And she'll unveil them, but be aware of them. Human resources, Sylvia continues to oversee that, and she is committed to bringing in innovative staff. So we're working through that. We are getting ready to say goodbye to Clarissa, so we're looking at a recruitment agency to bring us another good PT. So something like that, because you've been so good to us. So thanks. And then Michael, we're looking for also a replacement for you as soon as we can. And that's Sylvia's job. That's why we value that you all told us when you're leaving, because we start working on doing what we have to do. Front desk, Sylvia is committed to a fun training this year. Now, we're going to train you all year long, so enjoy her during this journey. The clinic side of it has been divided into 2 sections. On the PT-PTA section, Chole, Rudy, and Isaac are going to move us towards operations of the clinic as well as exciting new journey with the photo outcomes. Photo is going to be a really special tool for us this year. And then on the bottom section, PT technicians, you all are very important to us. You spend so much more time with the patient in terms of having opportunities to talk to them as you move them from station to station. You hear about their problems first. You hear about their dog's death way before us, or how painful they were when the Cowboys lost. That was a big thing that one day. Oh, it's like, and then we won't talk about the Pittsburgh Steelers, because that one then opened a whole nother. And the gym was loud for the next 3 minutes. Anyway, but we're committed to that. But for the technicians, Amanda and Chelsea are going to help us with the in-service part of it, with making sure. One of the new things that we're going to start is mentorship. So when a new technician comes in, and we'll explain this more, Amanda and Chelsea, when a new technician comes in, they're going to be appointed another senior PT technician. And they're going to help them walk through the whole process so that there's always someone that they can come back to. So our promise is new knowledge through a mentorship in that category. On the billing and finance side of it, that's Sylvia's division. She really wants to connect with patients' financial commitments. She does not want to, I wish I won't do any justice to the words. What did they say when a patient doesn't want to pay? What is our response supposed to be? Doesn't want to pay the copay because, oh, that's too much.
The rehabilitation, the sooner you finish your rehabilitation, you will be able to do your daily activities
that you used to do. So those cancellations, that phone calls can be so important to us. We don't want them missing. The sooner they can get their appointments in, the sooner they're going to achieve where they were before. So, and then internal marketing, finding strength from within. This is all of us right here. So all of us are just going to be moving through a lot of good changes. So this is our value stream. We're completely committed to it. We want to get the customer to cross over and meet all of us, and just know that we're ready to receive them and meet their unexpected needs, because some patients come in with lots of need. All right. I won't show you the last slide until we stand up and take a nice break. And I think this is the last one, am I correct?
Yes.
Okay. Yeah, I want to see, how do you rate?
That's why I replaced the blue ones to find my chocolate clock. That's what it was. I think at these they did have a check on you and but these are really comfortable and they're more stable.
Are they local? Oh, Durango.
I just like the stability because the legs tend to bend.
Okay, let's go. We're doing perfect timing. All right. So Sylvia and I were committed to bringing back opportunities to El Paso and to EPPTS. So this is an educational opportunity that I'm going to present because it was presented to us. All right. It's about the little book that I told you about. So when she stood up, and I think I sort of prefaced it last time, it's all the physical therapy opportunities that are really out there. We need to be looking for them. And here is, she mentioned the opportunity to speak of who we are and what we can do through the subject of pain. So I threw out these stats last time, but just for review, understanding, first of all, that there's a chronic pain science and then there's addiction science overlay. And they overlay. So two different type of sciences, but addiction is something that are not, we normally don't see in orthopedics, but they're hidden, these patients, in patient volume. And there's certain components that you should know if there's an addiction science component to them. But the whole thing that picked up speed was the opioid epidemic. Statistically, I mentioned last time that there's 5%, we are 5% of the world population, but 80% of consumers of opioids. That's just astronomically wide and too painful and difficult. The state of Texas is neighboring, to the left is New Mexico, Arkansas, not New Orleans, and who's above us? Oklahoma. All those three are high addiction states, all of them. And so and we are color white, so we're on the lowest end, Texas is, but we're surrounded by addiction. So drugs are going to be channeling very close to our state. And it was very interesting when I did some of my research for this presentation. 1 in 4 who are prescribed opiates go into addiction, and currently I think it's really important for us physical therapists to know, because I did not know this, that Suboxone is being used to mitigate the opiate withdrawal. So a pattern that they're seeing is these opiate addicted patients are looking for Suboxone. They are just trying. So they feel that that is going to be the new drug now, the new addiction. And that's just so that the withdrawals are much calmer, but we are really looking, and because it is also a drug that you can get very dependent on. So I think America's facing such a painful process right now. It's going to take a whole generation to fix this. That's what they're anticipating. Our country's strong efforts through the CDC, that's the Centers for Disease Control and Prevention, to reduce the opioid addiction has led to opportunities for our profession. They being CDC, they're turning to us to be part of the medical team to assist this reduction because of our knowledge in the neuroscience of pain. So the more you can take opportunities to learn, and her presentation wasn't long, but if anything, this is what I wanted to bring back to our clinic. Expect to recognize change in your patients in order to achieve successful outcomes. She said, if you are identifying that your patient is dependent on drugs and there's fluctuating, and there's one time Jay and I this year, we really felt that our patient was addicted on narcotics. I mean, it was like everything we were doing. It was very interesting, and at the time I didn't know some of the identifications, but he did me 2 of the 5 that I had learned. But she said, if you don't understand what we call the stages of change model, then you get caught up on the patient just coming in, because the doctor told me I have to do physical therapy, and that's the way. Without him or her saying that, that's the way I'm going to get my narcotics. So you're in that model of change. On number 3, most orthopedic patients fall right there. They're in that preparation stage where they're preparing to change, they want to change, but also understand that they may be under 1 or 2 where there's no recognition for the need to change. They like the drug, they want to come in, and they want to leave. So get a feel for where they are and move them through what we call the stages of change model. I think that the takeaway that I'd like to share with you on this one is that just know why your patients hurt and help them understand their pain, and that's why I wanted to invest in this book. It was recommended by the physical therapist that gave the presentation. And it's designed more for them, the book, but I certainly learned a lot from it. How many of you have had the following statement said to you by a patient? Why did my pain is so sensitive, and this didn't happen to my neighbor? They're always comparing, my neighbor had a total knee, and none of that happened to them. So the more that we can give them and look at time from this perspective and tell them, every human body is different, and then go a little bit deeper and perhaps, show them this picture, I think it'll start to help them connect. We're going to deal with their pain. One of the things that I learned about my knee is that it was so painful. at post-surgically. And Chelsea and I could not figure out why the lateral compartment was this hypersensitive. She would touch it and But I also had to understand that the chronicity of my pain had been hanging out for several months. And so my whole soft tissue structure changed. And I was very blessed I felt blessed to be a therapist because, at home, and thank you because the West Side loaned me their little my instrument assisted, and I beat the heck. I was all but, things moved and I moved through that pain, but I had a very unusual pain line. And so just remember everyone rehabs differently, but bring this, and this is an educational tool because we have committed to education in 2020. So this is the beginning of many that we're going to give each other. Okay, we are done, and it is 10 till 3. All right. Office staff, y'all are going to meet with Sylvia, and we're